Episode of JBassers Exposed Vet Productions. On this special day, it is Tuesday, August the 8th, 2025. This is kind of a makeup for last week. We had some technical issues, and so we decided that we can redo this show on Tuesday. We've got my co-host here today. Her name is Bethanie Spangenberg. She's owner of Valor Vet, which is a company that does veterans basically disability evaluations, independent medical opinion examinations, and she's good at what she does. She is a PA, and she's also an accredited VA appeals agent. And tonight we're going to discuss the cervical spine. We're going to cover the DBQ and some other stuff. Bethany, how are you doing?
I'm doing well, trying to stay hydrated in this heat wave that we're getting. So I'm currently traveling with family, so closer to the sun makes it even worse.
Mm-hmm.
So
Well, hope they're down to cool.
we are covering the Hopefully we have time for that. Even though it's a
Mm-hmm.
family trip, we've got stuff to do.
Yeah.
um, we're covering the cervical spine, and we've covered these DBQs for a while, and I don't know why I didn't think of it sooner, but we need to talk about the regular forms for disability applications, what those look like, and when you should submit them. More specifically, how we break down these DBQs, we should be breaking down those forms. And I bring that up because I'm actually helping a Purple Heart recipient who passed away. I've talked about this case before. I
Mm-hmm.
am helping his widow receive an attendance benefit. So it
Mm-hmm.
starts to get a little bit hairy whenever you've got a widow who also needs help. And so, um,
Mm-hmm.
we should start really breaking down those benefits and what those forms look like. So I'm also excited because I'm a visual person and I put a presentation together for the show to help any visual learners out there. If you're listening to it on the podcast, I'm going to try to describe the pictures and what's on my screen the best that I can, so then that way you can get some idea. But I'm looking forward to the presentation portion of it.
Mm-hmm.
So,
Good. That's really good.
all right.
People are interested in
Anything before
learning.
we get started?
No, just we need some cooler weather to
All
hit.
right. Let me go. Let's see if I can share my screen. Let's see. Let's see. Um, let's
Next
see.
to the leave button. There you go. Yes.
Let me see if it can give me the presentation. Can you see that?
Mm-hmm. Take
You
your
can see the whole
on your.
presentation. It's not, I mean, I, okay.
I see this, and you got the
Can you
left
see
side
me still?
presentation. Each slide. Yes, I see you still at the bottom.
Okay.
On your laptop.
Because the only thing yeah.
If if you
So the
press the
only thing that I
control.
can see,
Mm-hmm.
yeah.
If you press the control and plus button, just control plus, it might make that bigger.
You know what? I think on your end, on the controls end, you can actually
Mm-hmm.
change the viewer. And so then that
Hmm.
way the presentation, you can see it
Make it full
more
screen.
predominantly.
Wait a minute here.
Yeah. Let me see. Okay. Well, huh. So are you still seeing?
I see you, and I
I
see the
see you.
benefits. Right. You don't see it's up.
Okay.
Yeah, it's up. And it's pretty good size. I mean, it's a lot bigger than the last time we looked. So See if I can,
Oh, I'm trying to pull up our live feed so we can, um, anyways, so can you, gosh, why I don't understand why I can't see that. You can see the whole presentation?
I can see just the first page. Then but on the left side, the presentation is like your computer. I just see an image of your laptop.
Okay. Okay, see, I can't see that. That's funny. All right, so let me, I see what you're saying.
Mhm.
Hmm. Because see, if I hit from the beginning, all you see now is
Mhm.
my, um,
There you go.
let's just do it this way.
Scroll down. Oh,
Let me see if I can open it
4.71A.
up a little bit.
Mhm. Mhm.
There. We're
Mhm.
getting somewhere.
Um, Yep. Mhm.
There, I think that's good.
Mhm.
Okay.
There
It's
you
not the way I
go.
normally, present it, but this is the best I can do with this program. And then I can actually see what's going on other than just the slideshow. So that's good.
It's a,
All right.
it's a PowerPoint.
So t yes, this is a PowerPoint.
Okay.
Um, this is neck cervical spine conditions for the disability benefits questionnaire. These disability ratings come from the 38 CFR section 4.71A, and we'll talk about that as well. Let's see. Next slide. Okay. So we are going to look first at the anatomy of the cervical spine. I want to lay some understanding out there about how the cervical spine works, and that way you have an idea of each of these topics as we go through there and what the examiner is looking for. So if we look at the spine here, let's see, might need to zoom out a little bit. Okay. This is the cervical vertebrae, goes down into the thoracic vertebrae and then to the lumbar and the sacrum. The sacrum's cut off. But if we zoom in to one little segment of the spine, we can see the white material, which is represented for bone. The blue is discs. That's your, they're like jelly-like filled sacs that help to give flexibility, mobility, and protection in that area. Then the
Okay.
red, the one in the center is the spinal cord, and the ones branching off are the cervical nerve roots. Okay. So if we say, if we're talking about C1 or C2, we're referencing cervical spine number one, cervical spine number two, and so on and so forth. And then when it gets down to the thoracic, it transitions to T1, T2, and so on. Okay. If we look at the spinal column on the left, this is a healthy spinal column. In this, you can appreciate a smooth bone um, border, and this is the disc here. Okay. This space as well is good. There's no loss of the space or disc height. There's no herniation. The spinal cord, again, goes down the middle of these bones, and these nerve roots branch off. If we look at the picture on the right, which I think it's on your right if it's on my right, right?
It's on the right.
The vertebrae, the border of the vertebrae is not smooth like the other one. It is wavy and it's starting to deteriorate. Okay. The beginning of arthritis, osteoarthritis. Osteo for bone, arthritis is for joints. So we're starting to see wear and tear on the spine. The disc space is starting to get smaller. And if you can imagine, it actually starts to put pressure on the space in these nerve roots. And so we'll take a look at that in a different angle as well. Let me take this out. Um, this view is if we're looking at the top of your head down that bony vertebrae. Okay. So you can see the bony spinous process here. This is actually when you push on the back of your neck, that is the bone that you're feeling is that spinous process. The spinous process is protective. Okay. People can actually fracture these with falls or motor vehicle accidents. You can't go playing basketball or run and break a bone like break this bone like you can an ankle or an arm. Okay. This is usually uh, very traumatic injuries, such as a fall um, with underlying osteoporosis, a fall from a great height, a motor vehicle accident. Same for the transverse processes. These are to the side. Again, these are protective. That's just how the bone has developed to protect the structures along the spine. Because right here is very important. This is your spinal cord. The spinal cord goes right through the middle. Now, that hole in the bone is called the vertebral foramen. So sometimes, whenever you get your MRIs or your CT scan reports back, you'll talk about narrowing of the vertebral foramen, or you'll see hypertrophy of what they call the ligamentum flavum. Okay. The ligamentum flavum is a ligament that starts at the top of your head and goes right down the middle of your spinal cord and attaches it. Okay. It's the fibrous tissue that keeps that all together. And if you get thickening of that ligament, it narrows the area for the spinal cord even further and can make um, cause troubles, create problems. Now, when you stack these vertebrae on top of each other, they create a little hole for these nerve roots to come out. Okay. So that's why if we look back at this, we stack them on top, there creates a little bit of space there for this nerve root to come out. So if we look at diseases in the cervical spine, and this is important to understand, so then that way when you see medical terminology, you can get an understanding of what is happening. Um, in this picture, obviously, the blue is going to represent the bone. You can appreciate now when they're stacked on top that it creates holes for the nerves to come through. Just looking at the discs and the different types of disc disease, okay, this top one is normal. It's nice and smooth. It is full of fluid. It is what I like to say juicy. And I actually think of these like dried apricot because they're kind of fibrous like that. And sometimes you get apricots. I don't know if you ever have eaten dried apricots. Have you eaten dried apricots?
On
So
occasion,
you can
when
go ahead.
when you have nothing else.
Sorry. I love dried apricots.
No, I'm just kidding. You're
Uh,
okay.
but anyways, they're really juicy. They can be juicy if they're not dried all the way. And so I thought like, oh, this is a healthy disc. Like just because that's the way my brain works, okay? Um, and it's constantly medical. So it's just anyways, next time you eat an apricot, think about your disc. So as this juicy apricot starts to lose its juice, it gets the tissue around it is more mobile, and any movement you have in a joint space as far as like when it's supposed to be relatively stable, any type of movement within that space starts to cause arthritis and the wear and tear. So now you have this degeneration of the disc that allows more movement, and if you're doing lifting something, pushing, pulling, you're in a car accident and you have degenerative disc disease, you're able to get a herniated or bulging disc more readily. Okay. And so the bulging disc, you can see, starts to narrow this um, this pathway for those nerve roots to come out. So as we age, degeneration, and it can cause the bulging disc and then irritate the nerve root. The nerve root, when it's irritated, can cause numbness, tingling in the hands, um, weakness in the hands, numbness, and we'll talk about that as well later on in the presentation. Here we have thinning of the disc. Okay, that also comes with degeneration over time. This is essentially progressive that we're seeing. Now, when it loses the juice, you have more mobility in that sac because it's a sac filled with juice. So you lose the juice and it becomes more movable. Well, then let's say you decided to sleep on the couch and you wake up and you slept wrong and you put pressure on your neck wrong, you can actually herniate that disc. Okay. You can see that the outer covering is torn and that jelly fluid is coming out. Now, that jelly fluid isn't absorbable, it's still a fibrous gel-like material, but that will also irritate the nerve roots. More often, it's posterior towards the back here, so then it narrows the nerve root um, coming off the spinal cord. The last one here is the, again, more progressive disease that we see with arthritis, degeneration. We now have the loss of the disc height and the bone structure is starting to get um, osteophytes is what they're called. So they get little like, um, and these are weak. They're like little spurs almost, and they're
Yeah,
weak, and
bone
so they're
spur.
not strong and they're not good structure. It's the body's just trying to protect that space. So, all right. So enough about disc disease. When we look at the nerve root, when we look at the nerve roots, this is the spinal cord here. These are the nerve roots that come out of those holes in the side. These nerves come down into the shoulder, to the biceps, elbow, down into your fingertips, okay? This, when something is irritating the nerve root itself, so over here, this is called radiculopathy, okay? And when that nerve is irritated, it can be from inflammation from a strain where that muscle is tight and now it's causing pressure down to in that around that area and compresses the nerve. You can, with arthritis, bulging, disc herniation, you can get irritation. It can be chronic, okay? Typically, your chronic nerve injuries are something that develops very, very slowly. Maybe one day you'll wake up and you're like, man, this area on my thumb is bothering me. It's numb and I don't know what's going on. And then, you know, a year later, you notice that patch is bigger and it may be something that's very slow. And then you may start to notice that you're getting weak or you're dropping something. Sometimes it can happen more progressive or much quicker, but I wanted you to see visually that this is the spinal cord coming off the brain. These are the cervical nerve roots that come out and come into the hands. These nerves control skin sensation, they control temperature sensation, they control your muscles, and it also controls your reflexes. So you have a reflex down in your forearm, one at your elbow, one at your biceps that we test on a regular basis in the clinic. Any questions so far?
Me and
Oops.
all the nerves.
So in the clinic, when we do our exam, which is also what we do in the DBQ, we document where you're experiencing your symptoms. Okay. And based off of where on your body you are experiencing symptoms, we can get an idea of where in the cervical spine it's either narrowing for the nerve root or you have a disc bulge or herniation that's irritating the nerve root, but we know where we can expect to see one on imaging. Now, X-rays are not good for seeing any type of fluid material when it comes to the spine. You can see disc space, but you don't really appreciate disc herniation, disc bulging, unless, you know, I mean, there's certain circumstances, but we like to get MRIs or CT scans depending on what's going on. And most of the time, with contrast is ideal, but a lot of times kidney function will prevent us from getting that additional imaging with the,
Mhm.
oh my gosh, what am I
Mhm.
thinking of? With contrast, the word I was looking for, the word contrast. So, anyways,
Yeah, with that material.
so when we
It's
do the exam and we say, okay, well, thank you.
go ahead.
You're the correct person for me to forget that on. Um,
Mhm.
but like for this, if you tell me that you're having numbness along the top of your back that goes down into your arm and involves your thumb and other physical exam findings that suspect it, I can say, okay, well, I'm thinking it's like C6 or something that involves these two fingers, the first finger and second finger, then I can suspect that it's something coming from the neck. Now, what's
Mhm.
interesting, and it's something that I think is actually valuable for people in general to know, is that if you go into the clinic and you're like, "Hey, my fingers are numb," and it's like, "Okay, well, which fingers are numb?" And so, depending on which fingers are numb, I can see if the nerve entrapment is at the wrist, at the elbow, or at the neck. Okay. So these dermatomes help us put a clinical picture together of what we suspect, what disease is um, occurring. Okay.
It's a good guide.
All right. I'm going to actually speed through this one because since it's not a presentation, it won't have the visual effects. Um, this is part of the DBQ. Now we're going to jump into the DBQ. Okay. The DBQ is 14 pages. This DBQ, the one that is currently out, is much better than previous DBQs. And I'm actually very impressed with the improvements that they've made. And I have to actually give the VA kudos on this because when I was going through this, there's definitions in here that should have been in here 15 years ago. Believe it or not, I'm reviewing the Federal Register from 1964. I'm writing some history about it or whatnot, and the Federal Register from 1964 actually contains more clinical information for the examiner than the current um, Register does for today's veterans. And so the, there is a gap in time where veterans got very, very poor exams. And I'm hoping that that exam quality is improving as these DBQs improve. And I'll talk specifically about that as we go through here. So this DBQ, it's an hour to an hour and a half when it's face to face. It's 14 pages long, like I said. The first section, as with all DBQ, that's the section where the provider um, discusses the relationship that they have to the veteran. Okay. Next section is evidence review. Always, always, always statement in support of claim. Okay. You can see the VA form number there. Look it up, fill it out for your claim. Anytime you submit a claim, you should have a statement for each condition. That tells
Yeah,
the story for that condition, and the examiner can focus their attention to that statement, and they don't have to weed through and say, okay, this one's for the neck, this one's for GERD, this one's for sleep apnea. One statement per form for each condition. Okay. The other
mhm,
thing that you need to provide to the VA, don't depend on them to get it. You need to provide any x rays, MRIs, or CT scans. Like I said before, there's limitations with x rays, and we'll actually take a minute to look at some x rays. MRIs and CT scans tell a better story than what an x ray is going to tell us. The other thing is a nerve conduction study or an EMG. They're not fun to get, but if you're concerned that you have nerve involvement irritating those nerve roots, then you should be getting a nerve conduction study EMG. Okay.
mhm,
That tells a lot about the nerve status and um, that doesn't always pick up on the small fibers, which the cervical spine is the cervical nerve roots at the spine are large fibers. So this is not necessarily going to pick up diabetic neuropathy or small nerve fiber disease. This is mainly for those large nerve fibers, okay? When you get a nerve conduction study, it will also tell you, or can also tell you, if the injury is recent or if the injury has been chronic, depending on the type of waves that are in that EMG.
Mm-hmm.
A CMP examiner doesn't have to order a nerve conduction study for you. So if you have one, that tells a story. And in the clinic, to be honest, if we have a patient that we're concerned has radiculopathy, we're going to order an EMG. So bring one to your CMP, okay? The last thing that I want to recommend is that you provide them with your medical records, and you need to grab your physical therapy records. So, a lot of times you may see your doctor and then go to a different clinic or different hospital for physical therapy for your flare ups or for your maintenance or even chiropractor. But physical therapy is a big one because the person that touches a goniometer the most in their career is going to be a physical therapist. Okay. In the clinic, in general practice, in occupational medicine, me picking up a goniometer to treat a patient is few and far between. Okay. The people that mess this most is your orthopedic specialists. They are, or orthopedists, I guess, in general, and physical therapists. So a physical therapist will know how to use this goniometer better than anybody. So when you go to physical therapy, they will document your range of motion. And so you want to provide that information to the VA, especially if it's during a flare up. Okay. All right. So I'm going to back up just a second. We talked about the evidence. The next question that asks is it asks about dominant hand if you're left or right handed. And that's because hand dominance can get you a little bit more percentage according to the rating schedule. So that's important for them to document. Section 1 is the diagnosis. Okay, there's a whole list of diagnoses here, and I've presented to you the anatomy. So we're going to talk about the exam, and then at the end, we'll talk about specific diseases related to um, this DBQ and the rating schedule. Okay. Section 2 is the medical history. Part of section 2B, it says, does the veteran report flare-ups of the cervical spine? Now, when I would do these CMP exams, veterans would, what's a flare up? What's a flare up? I'm like, I wish you came here knowing what a flare up is because I need you to describe a flare up. So, according to this DBQ, what it wants the examiner to do is to include the frequency, duration, characteristics, things that make it better, things that make it worse, the severity, and any functional impairment that the veteran experiences during a flare up. In my opinion, a flare up is a temporary increase in your limitations or pain. The a lot of times the CMP examiners will mark no if you don't describe a flare up when they ask you about your back. If you don't mention a flare up, they'll put no. Okay, so you need to talk about these things. You need to be aware of what causes a flare up. You need to know that this question is going to be there, and you should be including it in your statement. Okay. So if they don't ask you, you have it in your statement and you've already showed the VA that you do have flare ups. Okay. And you need to know what causes a flare up before you even walk into the exam for the CMP exam. You can say prolonged driving, prolonged sitting, yard work, things like that. Okay. Um, all right. Question 2C talks about functional limitations. You need to give specific examples. So when I am doing my, after I've been driving for a prolonged period, I can no longer turn my head to the left and look over my shoulder. So provide a specific example. Section 3 is range of motion. Now, this is one of them that I was impressed with. Okay. Section 3, range of motion functional limitations. It says in here, if there is pain noted on examination, it is excuse me, it is important to understand whether or not that pain itself contributes to functional loss. Ideally, a claimant would be seen immediately after repetitive use over time or during a flare up. However, this is not always feasible. That was not previously clarified. It goes on to say this takes information regarding joint function on repetitive use is broken up into two subsets. And then it says it takes into account not only the objective findings on the examination, but also the subjective history provided by the claimant, as well as review of available medical evidence. So they are telling the examiner, listen to the veteran, listen to their history, and what they tell you is causing pain. Before, that didn't state that. And a lot of times still the examiner does not believe the veteran. Okay. And then it goes on to say, optimally, a description of any additional loss of function should be provided, such as what the degrees of range of motion would be to opine to look like after repetitive use over time. However, this is not feasible. A as clear as possible description of that loss should be provided. So what they're saying is use your clinical judgment. They're saying this is what the records show, this is what the X-rays show, this is what the MRIs show, this is what the veteran says. Take all that information and use your clinical judgment to give them a number. I have been talking about this for years. The clinicians don't do that. They don't want to apply their brain. That's why that whole speculation thing they started doing, actually, it's probably now 10 years ago, but I can't resort or can't opine, do resorted, I can't even remember it anymore. Resorts to mere speculation. That the term that they would use, that's crap. What that says that they're not using their clinical applications or clinical skills. So any CMP examiner that doesn't work in ortho, that doesn't use a goniometer on a regular basis, that doesn't have any occupational health experience, and or if you're a fresh new provider, you're really limited on your understanding of clinical application on these issues. So, okay. Any questions so far? I know I keep asking that, but
No, not
good.
really. I mean, fortunately, I've been through all of it myself.
Yeah.
More than once.
So if we look at this section 3 of the DBQ, this is the range of motion. This is what they're looking for. Okay, this is that goniometer I keep flashing. You're supposed to put it at the ear hole, and measure. Let's see. You go up, and then start at the nose, and then forward, and then backward. This up. Um, there's different ways, but my understanding is that's the most efficient way. It's actually pretty easy. The patient or veteran has to sit to do it. The VA considers 45 degrees normal. Okay, 45-degree flexion forward, 45-degree extension is normal. These pictures that they provide, this is a similar picture, but the pictures that they use in the current rating schedule were in there in 1964, so that hasn't changed. Your lateral flexion, this is bending your ear to your shoulder, and that's what I say. So when I do the flexion extension, I'll say drop your chin to your chest, and then look all the way up towards the ceiling. And then for lateral flexion, I say have your right ear touch your shoulder, have your left ear touch your shoulder. Okay. And that in those cases for lateral flexion, you actually put the goniometer behind the head and measure it from behind. Rotation, you actually put the goniometer right on top of the head. Okay. And then they rotate left, rotate right. Okay. So after each range of motion is collected, the examiner is to document. Now, before this DBQ came out and they had all those generic crappy DBQs, I would document where pain starts because The VA should be rating a veteran on where pain starts during range of motion. Okay. And in this new DBQ, listen to what it says. If any limitation of motion is specifically attributable to pain, weakness, fatigability, incoordination, or other, please note the degrees in which limitation of motion is specifically attributable to those factors identified. So they are saying, if they're saying they have pain, put the number down. Put the number down where that pain starts. And that was not previously in there before. So if you're looking at your examination and you're trying to see what they rated you on, it is under section 3 on page 4. Anything where it talks about where your limitation is, not the first range of motion or even the fatigability, they should be looking at your pain. Okay. And for you as the veteran, your pain starts when you say, ouch. Okay. You don't go, well, that kind of hurts. Maybe a little bit there, or that's tender. You go, ouch. You have to verbalize your pain. Okay. They shouldn't be asking you where your pain is. You say, ouch. You let them know. All right. I want to jump a little bit on from these because it gets kind of redundant. They want you to do each plane a single time and then multiple times for fatigability. The 3 times is supposed to basically show that your muscle structures, your bone structures are not able to continue at that current flexibility due to fatigue, which whatever, I guess. I don't understand how they do it. Let's see. Question 3C is repeated use over time. This is how they're trying to capture the fatigue and weakness of the cervical spine. And there's 3 little segments in here that they've added that I thought were fabulous. Does procured evidence, so that means statements from the veteran, and it says that, suggest pain, fatigability, weakness, lack of endurance, or incoordination which significantly limits functional ability with a repeated use over time? So they are asking, what does the veteran's testimony say? And they have to answer. That was never there before. It goes on to say, use your clinical judgment based on the information that they've given you and your relevant sources. What degree do you suspect would be caused from fatigue and weakness of the cervical spine? And then it does the same thing for flare-ups. Okay, they want them to use their clinical application, and it states it in there. And I've been saying that forever. You're supposed to listen to the veteran, use your clinical judgment, come up with something. You have to understand the disease to make the clinical applications. So, one thing that I thought was fabulous in reviewing this too is if for some reason you go to your C&P exam and it's a fabulous day, okay? And you're not really getting the good measurements that they should be. You can actually submit records from your physical therapist when you were treated during a flare-up. So if you get a flare-up, you go see your doctor or the urgent care and you're like, hey, can I get a referral to the physical therapist? And during that flare-up, you go in the clinic and they test your ranges of motion. And if during that flare-up, while you're seeing the physical therapist, it shows by goniometer testing that you have 10 degrees of motion, you could submit that as evidence for your rating. So I highly suggest that veterans start utilizing the physical therapy programs that are available to them at the VA. Okay. And when you go to appeal it, say, no, I deserve a higher rating. Here's why. Here's the evidence. They can reference those physical therapy records in their appeal. Okay. Page 7, 3E, it talks about, let me see where we're at. Not quite there yet. Page 7, Still on section 3, talks about muscle structure. The examiner is supposed to be pushing on their neck, pushing on their muscles, seeing how the muscle structure is stabilizing the cervical spine. Okay. Muscle strength testing. Section, I think, where are we at? Section 4. Okay. So muscle strength testing identifies nerve involvement of the cervical nerve roots. Okay. And if there's some compression of the spinal cord, it will pick up on some of this. So they want the muscle strength of the upper body, okay, the shoulders, the elbows, the wrists. And from a clinical application, we can say, okay, well, based off of their weakness, we know that this nerve root might be involved. And then we go further on and we do our reflex exam. Okay. That also looks at nerve involvement. It looks at that radiculopathy we're trying to investigate. Then we do a sensory exam. Okay. And then we put all that data in our head and we say, okay, based on my clinical experience, this is the type of radiculopathy that they have. And they want to know which nerve root is involved and if it's the right side, the left side. And so if we look at where we have to decide the cervical radiculopathy, we take those dermatomes, we take those reflexes, and we can come up with what nerve root we think is involved. Okay. And the examiner is supposed to put that in their report. Now, the new rating schedule only wants the examiner to look at motor function. They want everything to be rating wise based off of strength testing only. So you're completely taking out half of the story when an examiner is trying to investigate her radiculopathy. Okay. One thing I do want to highlight in in section 7 is that 7A on page 9 wants the examiner to ask the veteran about their symptoms of constant pain, intermittent pain, numbness, and tingling. If the examiner does not suspect that you have cervical radiculopathy, they may go on here and say you have none of that. If you are experiencing any of that, that should be in your statement in support of claim. You want to detail if that pain, that constant pain is mild, moderate, or severe. If that numbness is mild, moderate, or severe, you should be describing the quality and the type and where it's occurring. Okay. Okay, so now we're going to look at specific diseases because these are relevant in the rating schedule. If we look at section 8, this is ankylosing spondylitis. Okay, so we saw the normal cervical spine structure. If we look on the left, what this picture represents is that there starts to develop inflammation of the joints. Okay, so this can be from arthritis, this can be from an inflammatory disease. Um, Basically, it's an autoimmune disease where the body starts to attack the joints. Okay, and what happens is the bone regrowth becomes significant, that disc space is lost and these bones start to fuse together. Okay, so you can see here the disc space is lost. The bones, you have these spurs, they're starting to fuse together. Now, I have seen several patients with this, and most of the patients I have seen have had ankylosing spondylitis because of inflammatory conditions rather than severe arthritis, but I've seen both. This is in the rating schedule. Um, because they want to know where the ankylosing spondylitis is. Is it in the neck, the thoracic spine, the lumbar spine? And how is it fixed? Is it fixed in what they call favorable? So is it in a like anatomically correct position, or is it do they have a little bit of torsion in their fusion because people confuse with the crooked neck. What makes it even crazier is these bone regrowths are not strong. So you could have ankylosing spondylitis, have a fall, and break these little bone spurs off, and then get refused into a new position. And it's often not in your favor because we spend 8 hours plus sleeping or reclined in a position. So ankylosing spondylitis is not fun. It's actually can be very disabling. It happens in young youth too with inflammatory conditions. So uh, moving on to section other neurologic abnormalities. Oh, this is the one that John, you want me to talk about. I want to jump
Mhm.
up to this one right here for a second. Here. So this is the spinal cord. Okay. If you compress the spinal cord up in the cervical spine area, that spinal cord communicates from the brain and travels all the way down and spreads out into the feet. So if you have compression up high in this central canal, you can affect the nerve function all the way to your toes. So those
Mhm.
with a cervical spine fracture, I had one they were a pole vaulter for the military. He broke his neck and he became paralyzed from the neck down from that pole vault accident.
Mhm.
And that strictly has to do from those diseases or even a fracture that compresses that spinal cord. I've had a few patients where they would get an infection around the bone and that pressure on the spinal cord was too great and they never recovered and became quadriplegic. I had an older gentleman fall and break his neck, and he actually got a blood pocket in that area from the fall, and it compressed the spinal cord, and he's now quadriplegic. So anything that compresses that spinal nerve or that spinal cord that's central down that central hole there can affect lower. If somebody would have a spinal cord injury like at their belly button, it's going to affect lower and they're going to still typically they still maintain their upper body strength. Okay. So I wanted to make sure that because some people were like, well, they hurt their neck. Why are they having feet issues? And it simply has to do with the amount of pressure at the central canal of the spinal cord. Okay. All right. This is a big one. Section 10.
Mhm.
IVDS, intervertebral disc syndrome. Okay. This is a term that is no longer routinely used in medicine. It is a legal classification for rating purposes. The VA previously did not clearly define this for examiners. When I was there in 2011 to 2013, if it asked me if the veteran had IVDS and they weren't already service connected for it, I put no, because I don't know what that is. They didn't teach me. We don't use that term. So the VA has actually done a good job at now explaining it, and I will actually read the definition here to you. And then the clinician has to apply this to the veteran's case in order to determine if they have it. So IVDS is a group of signs and symptoms due to disc herniation with compression. So here we talked about these discs. Okay, here's the disc herniation. I think a disc bulge, or even they'll have like what they call protrusions, a disc protrusion. Believe it or not, the protrusion versus bulge has to do with how many millimeters it extends beyond the vertebral, the base there, which you didn't need to know that. So anyways, a group of signs and symptoms due to disc herniation with compression or irritation of the adjacent nerve root. That commonly includes back pain and sciatica. In the case of lumbar disc disease, and neck and arm pain in the case of cervical disc disease. Imaging studies are not required to make the diagnosis of IVDS. Okay. Now, here's what's interesting about IVDS. is the rating schedule has to do with incapacitating episodes with required physician bed rest. We no longer recommend bed rest for 95% of injuries, including back injuries. So if you are rated under IVDS, good luck. All right. I'm going
And
to
most
try
are
to
going to get
see where we're at.
60%.
What is it?
The maximum rating for that was 60% back in the day.
Yeah. I don't know how they would do it now because, like I said, they don't do it that way anymore, not in the clinic. Page 11 talks about assistive devices. You should put that in your statement in support of claim. I always like to document it because if you're documenting, when you're age 50 that you use a cane, well, whenever you need a walker, a wheelchair, or a caregiver, we can now document the progression. So I always like to put that in the statement. Section 12, I'm going to move a little bit faster. We're almost done. Section 12 talks about remaining effective function of the extremities. They did a fantastic job about adding details into the clinician. They added here, because it talks about whether or not the veteran would be equally served with a prosthesis. So they clarified that the question simply asks whether the functional loss is to the same degree as if there were an amputation of the affected limb. And so often if you have an ankle fusion, this should be yes. If you have an ankle fusion, you would be just equally served with an amputation and a prosthesis. Okay. Um, a lot of clinicians didn't quite understand that section in the past, but they did open that up and provide better understanding.
That's all considered loss of
Section,
use of the limb.
yes, it is. Next section is diagnostic testing. We covered that. Functional impact. The way they've written it now is improved. Let me read it to you. Regardless of the veteran's current employment status, do the conditions listed in the diagnosis section impact his or her ability to perform any type of occupational task, such as sitting, standing, walking, lifting? I've been advocating that for years, and I'm glad they finally did it. The last page is remarks in the examiner's certification. The last thing I want to cover here is clinical applications. So you can see in this x-ray here, this is actually a relatively healthy spine. Okay, the position is good. The disc space is pretty good. We don't have a lot of overgrowth around the base of the vertebrae. Okay. If we look at this one here, we can see there's a big difference. Okay. We've lost a little bit of that spinal curvature. We can see here that we've got that osteophyte formation. Watch it not be called osteophytes. Watch it be called something else in the cervical spine because I haven't done spine for ages, but I still read my own x-rays.
It is.
So I'm like,
It
oh,
is.
that's arthritis. Okay.
It still is.
And then the disc space here is gone. Okay. You can see that I have a disc herniation here. Okay. So that's what I'm saying is you can kind of see it, but an MRI or a CT scan is going to be more, um, show details
Clarity.
of that. What's also impressive of this is that we can see here that this individual has a chronic calcification due to inflammation of the thyroid gland. So that's an incidental finding on these. Okay. Now, we are talking about this x-ray, but your CMP examiners don't look at x-rays. They copy and paste what the radiologist is saying about it.
Yeah, the report.
In the clinic that I was, yep, in the clinic that I was in, I always looked at my own x-rays because there's times where I have the radiologist things, fractures. Plus, that's a clinical skill I never wanted to lose, and I don't plan on losing it. All right, there's one more here. Let me see if I lost it. I had an actual one of ankylosing spondylitis. I don't see it in here anymore. Must have taken it out. So looking
Mhm.
at the rating schedule, I have about 3 minutes and I'm done here, John. So I don't know if we'll go over, but I'll try to get through it. Looking at the rating schedule itself, these are your diagnostic codes. Your lumbosacral or cervical strain is common. Your degenerative arthritis, degenerative disc disease, other than intervertebral disc syndrome is common. The other ones, um, like the spinal fusion, the ankylosing spondylitis, we talked about those.
Yeah, that's my rating
This is
code.
the, pardon?
Mine's 5241.
5241. Yeah, yeah.
Mm-hmm.
Yep, there you go.
Okay.
This is the general rating schedule formula for it as we speak. Okay. And this has to do specifically related to the spine itself. It is not related to radiculopathy. Okay. So I'm not going to go over this. I just want it there for reference. People can pause the video. They can
Mm.
come back to it so they can read it. You can see what degrees. I'm not going to talk about each degree, but there's a range for percentages and degrees there. This is the rating schedule for the IVDS, and it is separate, and it has a separate rating. And this is the rating formula for that. So as you can see, 60% with incapacitating episodes having a total duration of at least 6 weeks during the past 12 months. And the note at the bottom says, for purposes of evaluations under this diagnostic code, an incapacitating episode is a period of acute signs and symptoms due to IVDS that requires bed rest prescribed by a physician and treatment by a physician. So, and I'm sure there's some legalities to get around that, especially because that is not today's medicine. And so you really can't apply that bed rest portion of it. So, um,
They need to update that.
yeah, I
Mhm.
agree.
Maybe
So,
we can ask some folks in DC to do something. Mm.
well,
Got
I
a
know
lot of
there's somebody I
doctors
won't ask.
that can take help. No,
Yeah.
I got a couple I can though. Mm.
Um, Here's our information. You can visit our website. Here's our phone number. We always talk about calling. If you're a texter, because I'm not a caller, you can text us too. We implemented basically an AI robot to answer the phone calls, primarily because we're trying to capture those after hour calls and those who want the information over the phone. Because you can talk to the robot, they give you the information. Anytime you want an actual live person, you can say live agent or transfer to agent, and it'll transfer you to a live person if we're open. If you get us after hours, you can text this phone number. Anytime we get text messages, it goes to the whole team and we all can get it in that moment. So let's say that Tyler that's in the front office, he's trying to help a veteran get registered and he's waiting on the veteran's computer to load. He had to restart his computer. Well, he's waiting to help that veteran. Well, you could be texting you at the same time he's waiting on that veteran. So um, feel free to text that number as well. Okay. So any questions? I know it's a lot. It's always a lot.
Well, this is a enormous section because you got a lot of spine issues, and there's a lot of VA disability that's paid, because of these issues. I mean, face it, the military's a dangerous place. And, there's recreation, sports activities, football, soccer, baseball, you're running and things like that. People fall, people get hit, and, especially in the Navy, you get these aircraft carriers that are big ships and they got a lot of ladders on them. And, there's
Yep.
nothing worse than going down a ladder head first. And, so, but, um, the VA, of course, I was on the old system, the old school, how they did it. And I think my CMP exam was like 3.5 hours long. And, but, anytime you got a spinal cord injury, like that, guys, the VA should take care of it. And if you have a neck injury while you're in service, now let me explain something. You might be okay. You might injure your neck, but 15 years after you get out, when arthritis sets in, you're not going to be okay. That's when you got to worry about the VA claim.
Yeah.
And that's true. Because if your neck looks
I
like
will say
mine, you're in
one
trouble.
last thing. I think,
Go ahead.
yeah.
Go ahead, Ben.
I will say that, you know, um, my clinical experience in occupational health has made a world of difference in understanding musculoskeletal diseases and their progression. Because you could have somebody that's, you know, spent a lot of their young years in the military and then they go on to do something sedentary. And you can see the difference in that story versus somebody who's worked in construction for 50 years. Or I know I say
Mhm.
50, but I don't think you could last 50, but for 30 years. You can really see like a story and their health conditions that progress. And so
Mhm.
I think that there needs to be more education, both in private practice for the VA when it comes to occupational health and not only diseases, but limitations that diseases can cause. A lot of primary care providers start to scratch their head when they're trying to like, okay, well, they hurt this. What should their weightlifting limitation be at work? And so with that practice and taking injuries and diseases, and I can say, you know, in a matter of time, like no pushing more than 5, no pulling more than 10 pounds, no
Mhm.
lifting more than X, Y, and Z. And that has really helped me with these veterans claims. And when I look at the records and the story that they tell, I can really kind of pinpoint when things really started to get bad. And so I think that's been a wonderful tool that I have developed that we use at Valor for Vet. So
Good. Well, Bethany, I want to thank you for coming on and doing this. It's a real informative show, and I'm sure we'll get a lot of feedback from it. And I'll forward you whatever we get. So, and if you guys need a good
okay.
IMO, give these folks a call. Can't go wrong with it. With that, this is John. Call me JBassers Exposed Vet Productions on behalf of Bethany and Valor Vet. We'll be shutting her down. Thank you, Bethany.
Thank you.